Our witness for this afternoon is Dr. Leo Elwell. Dr. Elwell, you've been sworn previously, correct? I understand, sir, that you are a physician licensed to practice in the province of Alberta.
That is correct.
And that you are certified as a psychiatrist.
Yes, sir.
For the benefit of the chair, could you just briefly go over your qualifications and training, including your employment up to today?
Okay. For 10 years, I was in the Air Force Reserve from 1982 to 1992. I then went into medical school after completing a Bachelor of Science. Got my MD from the University of Alberta, then finished the psychiatry residency at the University of Alberta. Then I was with the base as a civilian consultant psychiatrist from, man, am I nervous, 99 till 2009, right? Yeah, the timing works, sorry. Since then I've been most recently private practice as well as a consultant with the Primary Care Network in Sherwood Park. I also teach at the U of A in psychiatry.
And we heard the other day from Dr. Soa that, in fact, you did your residency under his supervision.
Yep.
We've heard a good deal, Dr. Elwell, about the base clinic and military arrangements for medical care. And it's sometimes a little confusing because we've got the base clinic, we have the medical health unit, and we have outside providers. I think it would be helpful to all of us if you could just briefly take us through a tour of that maze so we understand who does what, and also, especially with regard to the medical health unit, where it was physically located vis-a-vis the other facilities.
Okay. The military health system has a component that's staffed by military doctors as well as by civilian doctors because they can't keep enough doctors in uniform. And we come in and we assist primarily on an outpatient basis. So these are people being treated in the community. Then, when people require more intensive care, for example, if they come back with IED damage from Afghanistan, they would be treated in the civilian hospital system with follow-up provided by the military medical system. But primarily they'd be treated by the surgeons and that at the hospital. So in addition, we have the main medical clinic, which is located right next to the guard shack at the main entrance of the base itself. And then we also had the mental health clinic, which was a subsidiary of the main medical clinic. And we were located in a separate building, and then we moved the mental health clinic out to St. Albert for reasons of space and also for reasons of comfort on the part of the people that were seeing us. Then within the main medical clinic, we have the different care delivery units and or CDUs, and the one that was responsible for the Lord Strathcona Horse Royal Canadians was CDU Charlie, or C. And within CDU C, we would have a unit clerk responsible for paperwork. We'd have at least one, anywhere up to a couple of military doctors, depending upon their availability in that, and then a number of civilian general practitioners. And they were primarily seen as being the quarterback, if you will, of attempting to provide care for a person. So all the documentation, all the information would flow into them. And I'm, as a consultant, I'm advising to them, but I'm not primarily responsible for their medical care, right? And I would be providing them with what I felt was reasonable suggestions, and then they could formulate their management plan accordingly. The CDUs provided for continuity of care, so that usually you saw the same doctor, and if the one doctor was away, they would brief another doctor, particularly if the person was having a lot of problems like a respiratory tract infection or whatever. And that way that we could make sure that the person got the continuity of care. Because what happened with just military doctors is that you'd be away posted on a course or on a deployment or out in Wainwright on exercise or whatever, and you would never really see the same doctor. So one of the things that we tried to do with having the civilians there was that they would be providing continuity of care, and they would also know a lot of the medical employment limitations and various administrative functions that we have to provide to the member.
Okay. I'd like to get back to some of those questions in a minute, but I want to talk about one other aspect of treatment. I won't say medical care because I know that's controversial. We've also heard a good deal about base addictions counselors and the base addiction clinic. What was its relationship to the medical community?
The base drug and alcohol counselors, base addiction clinic was staffed by addiction counselors who were certified by their independent professional body. And they had a bit of a tough road to hoe, because on the one hand, they were to help under the auspices of some of the CFAOs. So let's say somebody has a positive urine test for marijuana or some other banned substance, right? They would be helping treat them with their addiction. Okay, and they would be advising the GDMO about, look, we need to send this person off
for the civilians in the room. GDMO,
General Duty Medical Officer.
And
interrupt me at any time. I'm sorry, it's German.
That would be the military doctor nominally in charge of a clinic.
Normally in charge of the CDU, yes. Okay. But it could be a civilian, as long as the base surgeon had said yes. I give you the blessing to be able to fulfill this role.
Okay. So I'm sorry, I interrupted you. They would liaise with the GDMO.
Yep, and they would liaise with me. They came to case conference every Thursday, and frequently we would talk about it when our paths crossed, when we were close to one another in the same building. Once we were out in St. Albert, it was a little bit harder because of just the, being 7 or 10 kilometers away, okay? But otherwise, there was a lot of conferencing that went on.
I'd like just to get you to explain to us a little bit the issues and challenges of maintaining confidentiality, and especially, we'll do it seriatim, but I'm interested in confidentiality as between the medical health unit and the mental health unit, and also confidentiality as between the base addictions counselors and whoever they needed to be maintain confidentiality for.
Yeah.
So let's start first with mental health versus medical unit.
We did it to the same standard. The medical employment limitations, where we say something like the person can't run because their knee is hurt, right? What we say to the unit is, unfit for running for so many weeks or so many months, right? And not any information per se about what's causing it, okay? But just to say that, look, you cannot employ this person in the following manner because of a medical concern, right? And then that way it allows the unit to have the person do appropriate physical training, and it also allows us to preserve the person's right to privacy, because the unit is the employer, as it were.
Okay, now, was there any issue of confidentiality about mental health records, even vis-a-vis the physicians who would be in the CDUs?
If something came out that was very, very private, so say, for example, somebody had been sexually abused as a child, then usually we edit that really heavy so that not a lot of it goes outside the room where myself and the patient is in, okay? So I'm not going to write gruesome details to go back into the main medical file, okay? But the main medical file itself is supposedly only accessible by health professionals who are guided by a code of ethics, by code of conduct, professional standards, so that they're not going to go blabbing about that to anybody. Then what happens is that a chit goes out to the unit that says that this person can't do PT for the next 2 weeks. And that's basically it. That's a medical employment limitation. You can't have them do PT, for example.
Okay. Now, what about the base addictions counselors? What constraints of confidentiality, if any, were they functioning under?
Well, there's when the unit would get a phone call from the base addictions counselor, they knew who they were and they knew what they did, so that it shouldn't come as a surprise to them, right? And, okay, so so-and-so has a bit of an addiction problem. Then what happens is that the forces had and still has a system whereby if the person starts going for treatment and complies with the requirements in the applicable Canadian Forces Administrative Order, CFAO, that then they can be, welcomed back once they've come back from treatment, and they're provided with follow-up so that they don't relapse to their addiction, right? And then if they do that and they follow the planned course of treatment, that it's not a black mark against them. And it's a very, very good employer trying to be supportive and trying to help people with this problem. And it's a good system.
Okay. I didn't include these documents in the collection for you because until you started talking about it, it hadn't occurred to me that I might want to ask you about it, but let me ask you then. In Corporal Langridge's file, we find documents that record a failed drug screening preliminary to deployment, and there is in the documents an indication by the base commander that he intends to order counseling and probation. And then we see an indication that Corporal Langridge wanted to challenge the accuracy of the initial test, and we then see a document suspending the counseling and probation until that process has run its course. And we see another administrative step where he asks for yet another independent test.